Hi everyone, how you doing? Oh, that is loud, isn't it? Yeah. Okay, so my name is James, and I'm a diabetes specialist podiatrist, and this is my colleague Trusha, who's the diabetes lead with Central London Community Healthcare. One of our roles is running the outpatient diabetic foot clinic in Chelsea and Westminster. Okay, so today I'm going to show 2 case studies of the 8 patients that we've successfully treated in a hospital setting. Okay, so but before I get started, I just want to talk about the goals and challenges with diabetic feet. This is, yeah, okay. So now obviously the goal with all wound care is to heal wounds, okay? As we all know, time is tissue. So as little time ulcerated is the goal. We want to avoid loss of life and limb, and having an ulcerated wound invites complications that increase the risk of amputation and death. Also, having these complications require more resources to identify and target these problems, so microscopy and culture, imaging, antibiotic prescription, medication prescription. Am I all good? Yeah. Okay, so diabetes is a very complex disease, and having poor glycemic control commonly results in vascular complications and neuropathy. So, both patients. Oh, hello. Hello. Yeah. Okay, cool. So, yeah, both patients I discussed have all got sensory neuropathy. So the damage of the sensory nerves mean that diabetics often struggle to feel pain, pressure, and extremes of temperatures, meaning they often don't realize when they've ulcerated. Also, both of these patients have evidence of motor neuropathy. So the essential short version is the uncontrolled. What's going on with this? Is it? Hello? Yeah, okay. So, where am I? Yeah, so the uncontrolled diabetes, which causes hyperglycemia in the patients, causes the intrinsic muscles in the foot to wear away and degrade because the motor nerves are being damaged. So that changes the general structure of the patient's foot, which causes high areas of high peak pressure in points that aren't supposed to take that pressure. So, as you can see there, we've got a really, like, I don't know what's going on. Hello? Yeah, so we've got this typical clawing of the toes. Okay, so then vascular is also a serious issue with the diabetics. So the increased buildup of the atherosclerosis reduces the arterial supply to the foot, and that slows the supply of oxygen and nutrients to the cells, slowing the rate of healing in the wounds. So, Mr. P is our first patient. He is a 61-year-old male with type 2 diabetes, peripheral arterial disease, and bilateral replacement of the hip joints. So, Mr. P attended A&E with sepsis, and then the left third MTP joint couldn't be ruled out as the source of infection. So it was probing deep with a large pus collection. So, the cause of this patient's wound is the biomechanics of the foot, essentially. The patient has hallux valgus and a plantar plate tear. There's no doubt some contribution from motor neuropathy. So, as we can see from the photos, that area of high pressure is building up a lot of Hello? No, it's not me, yeah. Hello? Yeah. It's building up a lot of callus, which is delaying the healing and risking further complications. So, during this, the patient had regular weekly podiatry treatment, which was aggressive debridement and offloading with 𝗱𝗲𝗯𝗿𝗶𝗱𝗆𝗆. So, despite all of this, as you can see, we weren't able to get the wound closed. So, all those previously mentioned complications were at risk of. So, it stayed static for a number of weeks at this point, and so all of these photos were taken. Yeah, so photos were taken 9 months post DEBRICHEM. So, as you can see, that really difficult to close gap has been slightly reduced, and we're seeing the wound slowly reduce in size and depth. So, then, 17 weeks post DEBRICHEM, wound's fully intact. So, Mr. P in February was able to go to Malta and could go into the sea, which is an excellent result. Okay, Mr. F is our next patient. So he's a 64-year-old male with type 1 diabetes, peripheral arterial disease, neuropathy, hypertension, and Barrett's esophagus. Well-known patient to us. He's been under acute podiatry for about 10 years now. So as you can see, he's previously had a right fourth toe amputation. So Mr. F attended the outpatient clinic with a right fifth plantar lateral wound because of a blister in October 2022. The wound was treated with podiatry treatment and aggressive debridement, offloading with 𝗱𝗲𝗯𝗿𝗶, and a post-op 𝗱𝗘𝗠 An MRI confirmed osteomyelitis up to the fifth distal metatarsal, and this required a fifth ray amputation in May 2024 under vascular. So the patient underwent an angioplasty of his right anterior tibial artery under vascular, but the posterior tibial artery was unsuccessfully recanalized. And though there was
Sorry about the technological issues.
Yeah. So, though there was evidence of peripheral neuropathy, the patient also found sharp debridement really painful. So, for these reasons, we used DEBRICHEM post-amputation in the clinic. Now, okay, here are a couple photos of the DEBRICHEM application. So, the first. So the foot previously has had 5% 𝗱𝗲𝗯𝗶𝗃 cream applied and left to soak in for 15 minutes. So really easy application to the foot. Just pour the liquid on the area, rub it in, and leave it for a minute. Then neutralize with saline and apply an antimicrobial dressing. So of the two cases we've discussed today, this is the only example of a patient that experienced any pain during the treatment. So a few things to consider though. So we applied 5% 𝗱𝗲𝗯𝗶𝗃 cream to the wounds because we weren't able to get 10% 𝗱𝗲𝗯𝗃 cream on such short notice. And this would no doubt reduce the feeling if this was applied instead. Alternatively, if anyone is trained in tibial blocks, you could go local anesthetic. So as see from the picture on the right, already that area has started to turn black. So it forms a very hard protective layer to the wound, almost like an eschar. So it slowly peels off, and underneath we'll have a nice, healthy, underlying granulating base. So, as we can see, 14 weeks post-DEBRICHEM, the wound is fully healed, and the patient is currently being fitted for bespoke footwear that will allow him to remain dressing-free. So, Mr. F is getting these shoes fitted, and this will allow him to wear closed-toed shoes to his brother's wedding. So, in conclusion today, DEBRICHEM is a very cost-effective frontline tool at healing wounds. DEBRICHEM is very effective at removing biofilms, cleaning wounds, and that will facilitate faster wound healing. Of course, all this means we've massively improved the patient outcomes. So, in the two cases I've discussed today, fully healed foot wounds, and they are able to continue their active daily life because of DEBRICHEM. Now, if I haven't persuaded anyone with the patient stories, here's just a few facts and figures to show the money it costs to run a high-risk service. So these values are like the mean averages over the patients we've discussed. So the first one is okay, so yeah, the first table is before and the second one is after. So a very clear reduction in the costs required to treat these patients following the application of DEBRICHEM. Yeah, okay, so finally, this is the other costs. The previously mentioned complications we have successfully avoided because of DEBRICHEM. Thank you very much.